would like to move to the next talk by Dr. Ankur Singh, who is the chief instructor of this course, and he is working as an associate professor at UCMS Medical College, GTB Hospital in Delhi. So he'll be talking on posterior uveitis enhancing diagnostic accuracy with OCT angiography.
A very good morning, everyone. So I'm going to talk on posterior uveitis, enhancing the diagnostic accuracy of OCT angio. So as we are aware from the previous talk, OCT angiography has already proven its mettle in diagnosing macular and retinal pathologies. How far the diagnostic utility of OCT angiography in posterior uveitis has been there, and what are the the recent utilities, what I'm going to talk about. So FFA and ICG has already been a gold standard in the diagnosis of and management of posterior uveitis. Dual FFA and ICG gives a global information about the structural alteration of the central as well as peripheral fundus. It's a dynamic invasive test, as we are all aware of. It shows leak unlike OCTA. So it can show the vasculitis very well. It works okay with patients with mild vitritis. It has global consensus on the nomenclature, and it is a well-researched tool and has been used by clinicians for over 20 years. On the other hand side, we have OCT angiography, has been discussed by Dr. Devesh. That's a fast, nascent, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormalities. It provides us with the structural, perfusion, and vascular flow abnormalities. So unlike FFA and ICG that treats retina as a single layer, it can detect blood flow abnormalities in superficial, intermediate, deep retinal capillary plexus as well as in choriocapillaries. So there are the OCT angiography has been described in various retina uveitic pathologies, but in the paucity of the time, I'm just going to touch upon the important ones. One such would be white dot syndrome. So this is a patient of acute posterior multifocal placoid pigment epitheliopathy. What you see them as clinically is these whitish, yellowish placoid lesion. You do an OCT in these patients, you see those outer retinal hyperreflectivity with the affection of the IS-OS junction, secondary to the capillary ischemia. You do an FFA in this patient, you do see hypofluorescence lesions which become hyperfluorescent due to staining, and in ICG you see them on as a hyposenescent, which remain hyposenescent in the later stage. On OCT angiography, you see them as these flow void areas. So how does it help you to differentiate based on the OCT angiography from the other white dot lesions? So another white dot lesion is multiple evanescent white dot lesion, which again looks like these pinpoint white lesions, which are seen on OCT as an outer segment loss, photoreceptor segment loss. You do an ICG in this patient, again you see these flow void areas, so you see these hyposenescent areas. But when you do an OCT angiography in these patients, you don't see any flow void areas in the choriocapillary plane of OCT angio. And this is where the utility, or this is where the limitation of the OCT angiography helps you to clinch the diagnosis. So OCT angiography cannot detect blood flow in smaller capillaries. So although there is a choriocapillaritis present in multiple evanescent white dot syndrome, there is no flow void areas on OCT angiography. So it helps you to differentiate between this white dot syndrome. So as we are aware that multifocal choroiditis is 1/3 of these patients are associated with CNVM complex. So again, if you see these whitish lesions, you do an OCT and OCT angio, and one of the few lesions you see a CNVM complex, which is very well delineated by the OCT angiography. Probably you're looking at a patient of multifocal choroiditis. Again, one thing which is very common in tubercular granulomas is the RAP lesions. And if you see these abnormal flow in the various NFAS images from top down to the up, from the top up to the down, as well as the flow in the retina, the flow overlay in the retina, probably you are looking at a RAP lesion. So although VKH is something which is a granulomatous disorder, which can be diagnosed clinically and has been very extensively diagnosed on FFA and ICG, so what the study shows, the study that was done in PGI when I was there, that showed that 94% of the patient who had granulomas on ICG were able to detect it by an OCTA. And what is the benefit of it? First, it is non-invasive. You detect those lesions as the flowoid area, as you can see in the left middle picture. You start the patient on the treatment, and these flowoid areas resolve. So once these flowoid area resolve, this will help you to guide the end of the treatment for VKH. So this is another utility of OCTA using the choriocapillaries images. So now this is a patient of retinochoroiditis, and you do an OCT, you see those hyperreflective various deformation in all the layers with ERM present. You do an OCT angiography in these patients, you tend to see these not flowoid areas, these are the areas which are showing no flow. So in the superficial, deep, as well as in choriocapillaries, probably you're looking at retinochoroiditis. And at the same time, if you do an FFA, you might miss those, small satellite lesions. But you do an OCT angio, look at those yellow circles below in the image. You will find that you can clearly see those, satellite lesions. So if this patient is coming to you in a later stages when he is healed, although for a good clinician and CNVM complex, but if you're in doubt, you tend to do an FFA, but just don't do an FFA, do an OCT angiography, and you can see a CNVM complex. Now, as been discussed previously, the OCT angiography cannot show leakage. So how do we diagnose diseases like Behçet's uveitis or any other uveitis? First, OCT angiography is not affected by the leakages, and you can clearly see the CNP areas. And as we have evolved in time, we've understood that the decrease in the vessel density in the superficial as well in deep capillary plexus around the FHS can tell us that the disease is progressing. So if you see that although clinically you can see the disease is not progressing, but if it is there, this means the treatment needs to go on. So OCT with the wide field OCTA, which has been described previously in the previous talk, diseases like IRWAN, which is idiopathic retinal vasculitis, aneurysm retinitis, can be diagnosed by using a wide field OCTA. So another entity which is very common in our countries, which we are endemic to, is trabecular serpiginous choroiditis. So we do understand that we see those yellowish white lesions as the active form, but they do an OCTA. How do you see them on the OCTA? Is those these areas which are circled in the yellow is the flowoid areas with certain hyper reflectivity around it. So when the disease resolves, you see an OCT which shows atrophy. At the same time, visualization of deeper choriocapillaries on the OCTA can help you to understand that probably you're looking at a healed lesion. So although OCTA cannot detect leakage, but it can detect reduced vessel density, suggestive of active vasculitis. Decreased flow in the deeper capillary plexus can be a promising imaging biomarker for disease severity in diseases like birdshot retinochoroiditis. In granulomatous uveitis, OCTA has a 94.2% agreement with the granuloma seen on ICGA. Flow deficit depiction, especially in the deeper and the chorioretina, may not be a flowoid area, rather a necrotic retina with no detectable flow. Therefore, always correlate the structural OCTs with the NFAS OCT as been discussed before. And the interpretation of the various pathology in uveitis is still evolving. So lastly, OCTA is not an alternative to an ICG or FFA in uveitis, but a respectable adjuvant. As like with any new investigation, OCTA requires standardization. keep limitation of OCTA in mind while sorry, while interpreting the pathologies on OCTA. Thank you.